Next presenter is Dr. Gatt, who's going to talk about glenohumeral injuries, but particularly paying attention to anterior shoulder instability.
Okay. Thanks, Eric. So this is a big topic. I'm going to try to move through it. Like Eric said, we could have an entire symposium on glenohumeral instability and spend all day talking about this, but I'm going to try to hit some important points that I think are good take-home messages. Instability, this is what we see and deal with most commonly. So again, what I want to try to talk about is, the things I want to hit upon are surgical indications for anterior instability. And again, one of the controversies that exists right now are what are the surgical options for the contact athlete, i.e. arthroscopic versus open surgery. So again, this is kind of a typical case where we'll see a teenager, adolescent guy, or college kid who's goofing off in his room with his roommate and falls out of the bunk bed while they were wrestling and ends up with a dislocated shoulder. And you can see on physical examination, it's pretty easy to tell because his shoulder is squared off. There's his acromion. His humeral head is sitting down here anterior inferiorly. And Dr. Swan later on is going to talk to us about what are the best and easiest ways to get this back in without too much difficulty. So I'm going to stop that. I'm going to skip that step and move on to, what do we do after these patients are reduced and how do we manage them? So one of the most important things in evaluating these patients and how I'm going to manage them is, what is the history. I really take a lot home from the history. So I want to know, was it a traumatic or a atraumatic dislocation? So that kid is a kid who, again, was a relatively traumatic event. But, I've had people, first-time dislocation, they were just rolling over in bed and they dislocated their shoulder. If you examine them, it's usually a female, and they can usually bring their thumb to their forearm and their elbows hyperextend. They have a hyperlaxity syndrome, but that's really critical. We want to know the position of their arm at the time of the dislocation, because people come to my office or to the training room reduced, and they're, were they abducted and externally rotated? That's going to be anterior. Did they fall onto an outstretched arm? That might drive them out posteriorly. You see so many kids who, like the players who dive back into the base, and their arms are out extended. That's generally going to be an anterior because their arm gets pushed up this way. You'd think they would slide out the back, but then our offensive and defensive linemen, they're going to get pushed out the back. So you want to know the position of the arm at times. And then, again, it goes back to history. Is this their first dislocation, traumatic or atraumatic, or have they dislocated so many times that they can't even count how many times they've dislocated? And was the first one really violent, or was the first one, relatively low energy? Did they ever develop neurologic symptoms? Typically, I'll ask them, do you get a dead arm syndrome? Maybe because they don't dislocate, but they just subluxate, and their biggest complaint is after playing, their arm goes dead halfway through the match. I had a wrestler at Ryder, and within 2 minutes of the first period, his arm would go dead. He wouldn't dislocate, but he'd have an arm hanging at the side, and somehow this kid could wrestle, 2 more periods, until one time his numbness had stayed for 3 days, and we're like, well, that's enough. So, and then in the office, you're probably not going to see it with athletes, but we do see people come to the emergency room more than the office who are voluntary dislocators. They could be drug seekers, or it just becomes habitual. The kid who says, yeah, I can go to the party and do a Mel Gibson and pop their shoulder out and pop it back in against the wall for an extra beer or something like that. Radiographic evaluations, I think, always want orthogonal x-rays, meaning, at right angles to one another. So the typical is going to be an AP view and an axillary view. Sometimes, if the patients can't lie down, or there's not a good way, you can do this view called the Velpo view, where you can put the beam on the plate on the table, have them lean back, and still get an orthogonal to the AP view. What do we look for? We look for Hill-Sachs lesions. If you get a view called a Stryker notch, which is the arm maxillary internally rotated, that'll show your Hill-Sachs lesion, where the indentation fracture on the humeral head, where it bangs into the glenoid. We look for Bony Bankart lesions, where the ligaments avulse the rim of the glenoid off. That's best done with a West Point view. And these are kind of historic because in these days, everyone's going to get an MRI or an MRI arthrogram. Then it's going to tell you a lot of that stuff anyway, but it's still good things to know. So you have this first-time dislocator, and for a long time, there's a question about, you put them in a sling, how long do you sling them? But then, there was a period of time back in the early 2000s where there was move that said, well, we can actually reduce the recurrence rate if we immobilize them in external rotation. And why is that? Well, theoretically, most slings, the sling's going to put your arm in internal rotation, right? The injury was to the anterior capsule. So what you do is you put your arm in internal rotation. There's no tension on the anterior capsule. The joint fills up with blood. There's a hemarthrosis. So it kind of pushes the capsule away from the glenoid and the labrum away from the glenoid. And that's why it maybe doesn't heal down. So this theory was that if you externally rotate the shoulder, then it will bring the anterior capsule, make it tight, pull the capsule and the labrum against the glenoid, and maybe increase the healing rate. So this was met with a lot of fanfare. Here the patients were treated with internal rotation, had a lower redislocation rate than the patients. If they were treated externally rotated, they had a lower redislocation rate than internal rotation. So, but the problem with this particular technique is that patients aren't compliant with it. It's hard to put somebody in a gunslinger sling and ask them to stay like that as opposed to the regular sling. And most high school kids are taking their sling off as soon as they feel good anyway, so it really doesn't matter. But again, some basic science work was done and showed that to have the maximum contact between the labrum and the capsule against the glenoid, you have the shoulder 45 degrees externally rotated. So you can imagine walking around like this, for 3 weeks. I mean, how many people are really going to do that? So, and again, then they looked at Cochrane Review, looked at it and said, there's not as much of a difference. So there's been some more studies that show that this external rotation technique doesn't really make much of a difference, and it's probably more of a compliance issue. And it's kind of fallen out of favor. I don't really know anybody who's doing it. We don't do it in the New Brunswick community where our residents manage both St. Peter's and Robert Wood Johnson emergency rooms. So it's something that's gone by the wayside. Then another thought was, well, how does a mobilization make a difference? Can you mobilize them for 3 or 6 weeks or 1 week, or does a sling even make a difference? And basically, if you review the literature, length of immobilization makes no difference. So again, even first-time dislocator, I'm putting them in a sling for comfort only, and that's the only reason they wear a sling. As soon as they're ready to come out of it, they can come out of it, because I don't think I can change their recurrence rate, and that's the only thing I'm really concerned about as far as the sling has to do with their treatment. As far as, the biggest risk for recurrence really is age. I mean, that's really what it comes down to. You have a 17-year-old athlete who dislocates their shoulder traumatically. They're going to have a redislocation rate anywhere from 60 to 90%. The older people get, the less their redislocation rate is, and that's, relatively straightforward. This is a kind of a more recent study, 2011, where somebody did a mathematical analysis of the risk of recurrence, and based on age and activity level. And there's an example of an 18-year-old male who redislocates his shoulder. He's got a 77% risk of redislocation at 1 year, but if he has a stable shoulder, if it doesn't come out, then his redislocation rate goes down as time goes on. So what you find is that if they're going to redislocate, they're going to redislocate early. If they make it through the first year or two, they're probably going to be okay. And again, that comes down to your role of surgical intervention. Like one girl who was a surfer who comes to see me, she dislocates her shoulder once a year surfing, and she pops it back in, she comes in, x-rays negative. I said, you want surgery so this doesn't happen? She says, no, I can handle the one dislocation a year. And then now she's gotten older and she doesn't dislocate anymore, even though she still surfs. So what can we do to enhance the role of non-operative management? Well, the first thing we do, once they recover from the pain of the dislocation, we're going to work on rotator cuff strengthening exercises and scapular stabilizing exercises. I think that's one of the things that people don't pay as much attention to is the scap stabilizing exercises. I mean, Dr. Monica just showed you the importance of the scapula in terms of glenohumeral stability, and it really is a big part of it. So not just having them do empty cans and external rotations, but things like push-up plus, work doing seated rows and things like that to control the rotation of the scapula. And then in the athlete, we can look into bracing techniques. So there's a lot of braces out there. There's some that are big and cumbersome, some that attach to shoulder pads, depending on the type of athlete you're caring for. But essentially, what they are, they're a tether. They keep the arm from going into abduction and external rotation to a certain level. So an interior lineman can use a brace without much difficulty. A wide receiver may not be able to play at a high level with that restriction of motion. But a linebacker might be great for that brace, because as he reaches out to pull a linebacker coming by, or a running back coming by, that'll help him. But a basketball player who needs to get his arms up high can't tolerate these braces. So you just have to, for the appropriate athlete, these are really good techniques to either get somebody through the season or maybe get them through their career, right? You have these athletes who injure their shoulder as a senior in high school or a senior in college. You say, look, if you can just make it through this one more season, odds are if you go into the real world and get a job and stop goofing around, your shoulder probably won't come out that often, and you can get them by without surgery. So these are very helpful and have been very successful on field management. Again, this is just more evidence that, if we're going to treat them non-operatively, brief immobilization works. Physical therapy, if you don't have the access to an athletic trainer, can keep people being compliant with their activities. This is another good study by Sachs that showed the prediction of future instability. And it is interesting, in patients that were young, the number of hours they participated in sports did not impact their redislocation rate. If it was going to come out, it'd come out in just a small amount of activity or a high amount of activity. But the patients that were treated, even the contact athletes, when they redislocated once or twice, they didn't necessarily want surgery. Get their shoulder popped back in, they get back on the field, and they figure, again, if I can make it through. So redislocation isn't always the reason to reoperate on somebody. It depends on the frequency of dislocations. You certainly have patients, we talked about the extreme athletes or someone who's just I've operated on a few people where I say, look, we're going to do this operation. You have to wear a sling for a month or 6 weeks. They come in for their post-op visit. They're 10 days out from surgery, and they have no sling. Already I know that they're probably going to pull apart my surgery because their arm's just flailing all over the place, despite the fact that I told them they were trying to stiffen up their shoulder. So non-operative treatment in athletes, I think, again, we have that mid-season athlete. What do we do with him? I think the important thing to tell those patients is they want to know, if I redislocate my shoulder, am I doing harm or damage to my shoulder? And the answer really is no. The risk of a repeat dislocation really isn't that high. I mean, if they come out in the game the second time, it's easier and easier to pop them back in. Are they going to end up with any chronic neurologic problems? The answer is no. Again, we talked about the role of a brace, and it works really. So this is a nice study, 2004, where they treated in-season athletes with no immobilization. A Duke wire brace is another brace that prevents abduction external rotation. 37% of the athletes had a redislocation in the same season, and eventually about half of the patients went on to surgery. But the point being, more evidence to show that you can safely take an in-season athlete, rehab them, and again, when are they ready to go back? You can't predict. You can see a kid who dislocates his shoulder, and he may take 3 or 4 weeks to get his strength back. I saw a fellow who dislocated his shoulder in a football game, and figured he would be out. I examined him after the game, and he had absolutely full motion and absolutely full strength. What's the sense of holding him out the next day? I mean, he's already ready to go. So you have to examine the patients, and that's really how you're going to make your decision. Injury patterns, we'll just go over what we see. You hear a lot about it, and some of these injury patterns have an impact on whether we recommend surgical treatment early versus late, because some of the injury patterns have an impact on redislocation rate. These are labral lesions. In other words, a labrum pulls away from the glenoid, but there are some capsular lesions as well that we'll see. So this is the classic Bankart lesion, and this is where the labrum and the capsule have pulled away from the glenoid. This is the mid-level of the glenoid. This is the inferior glenoid here. You can see arthroscopically that that's separated away, and the reason people recurrently dislocate is because this doesn't heal back down. Now, an ALPS lesion, which is a labral injury with a periosteal sleeve avulsion, they have these acronyms in shoulder surgery. Here's the labrum and the periosteum. Here's the glenoid. You'd see how it's actually rolled up almost like a shade, and it's medial to the glenoid. So when you see that, here's your glenoid rim, here's your labrum and the periosteum. This probably has a much higher redislocation rate than the other one, than the Bankart lesion, right? Let me just go back real quick. You can see the difference here, where everything's kind of sitting right there. That has a chance of healing. Whereas even if this one heals, it's healing. There's no bumper effect. You've lost your whole containment concept of the labrum. And if I see that on an MRI arthrogram, I'm probably telling the athlete they're better off getting that fixed rather than waiting. Because the longer you wait, this scars down below, and it won't. It's harder to pull back up into the proper position. A Gatt lesion, so this is a dislocation that in addition to the labral injury ends up with some articular cartilage pathology that may have an impact on degenerative arthritis later on in life. We're not really sure. And then Bony Bankart lesion. So again, this is a patient that I took care of glenoid here. Here's his anterior inferior labrum. You can see, remember, talked about the pear shape of the glenoid, but he basically knocked off about 20%, or at least 20, maybe 25% of his glenoid rim, and here it is arthroscopically. You can see a fresh bone bed. We can actually fix that either arthroscopically open, and there's some debate about what is the best way to approach that procedure. And then there are ligamentous injuries, mid-substance ruptures. The things that we don't pick up as much on MRI are humeral avulsion of the glenohumeral ligament, otherwise a Hegel lesion. So as opposed to separating the labrum from the glenoid, the capsule pulls away from the humeral head. Whether, so now you have your first-time dislocator, so how do we treat them operatively versus non-operatively? And this is actually, there's some really good level 1 evidence. It's been studied a lot. Sandy Kirkley, who is probably one of the leaders in randomized prospective studies out of Canada, did some great work. And essentially, if you look at all the studies, Craig Batani's in the military, you can tell somebody, if you have a first-time dislocation and I treat you surgically, I can almost guarantee you that your recurrence rate is going to be lower. It's not going to be 0, it's going to be a lot lower. So you say you have anywhere from a 10% dislocation rate, 20% dislocation rate versus a 60 to 90% redislocation rate. That has a big impact on, let's say it's a junior who dislocates their shoulder. He's got 1 more year to play sports, right? And he says, well, now I've dislocated my shoulder, should I get it fixed or not? He doesn't want to miss out on his senior year. He's put in all this time to become as good of an athlete, and he's kind of the last thing you want to do is tell that fellow that, well, we'll try you non-operatively, and the second game of the season his shoulder pops out and he can't get back. That's crushing, where if you treat him surgically, you decrease his chances. So if it's a freshman, I might say, well, what happens? Because again, we know that people who redislocate, can get back and play safely if it's not too many dislocations. But if you don't want to miss out on an important part of your career, these kids who think they're getting scouted and they can't have injuries at the time, they might be a little bit more aggressive surgically. And you have a lot of evidence to support that. As far as surgical stabilizations are concerned, again, we go into a lot of detail about the procedure, but essentially what you want to do is you primarily want to establish or reattach the anterior band of the inferior glenohumeral ligament and that bumper effect of the labrum. So remember I showed you that Alps lesion where the labrum had fallen down below the glenoid. We're going to bring that, if we take this tissue, which usually is sitting inferior to where it belongs, and reattach it back up here. And one of the things I always talk about when I examine people is I'll look for elements of capsular lax. They have that, the elbow that hyperextends, could they be really loose jointed? So in addition to an anatomic of the capsulolabral structures, I also want to decrease that capsular volume so that I start to get rid of some of that multi-directional instability component that may be present in some of those athletes. That's the second thing you need to address surgically. There's been a fair amount of debate versus open versus arthroscopic. Many years I've been practicing long enough now that I've seen, I'm just going to move this up, excuse me for 1 second. There we go. I've seen the kind of everything go full circle. There was a period of time when arthroscopics took off, then they looked at the long-term follow-up, and the recurrence rate was higher, so they went back to opens. Improved techniques, and the improved techniques are now starting to show that the arthroscopic techniques work as well as the open techniques. So it's kind of 50-50 in terms of what I recommend to people. I think most surgeons should do what works best in their own hands. I have long-term follow-up on open surgery where patients are doing really well, but now the arthroscopic techniques are matching those. So again, we have really good information that these are just about even. There's been some recent data that shows that maybe opens have a lower redislocation rate, but really if you really kind of pare it down, what we're finding is that the higher redislocation rates are occurring in contact athletes and athletes that have a combination of labral pathology with some bone loss, either a relatively decent-sized Hill-Sachs lesion, a decent-sized wear of the anterior inferior glenoid, or maybe a combination of the two. And again, what I will say is that if I see a patient who's had multiple dislocations, do I want to treat them arthroscopically? If I think they have had too many dislocations where into the labral pathology, they've stretched out their capsule, and I don't think I can address that capsular volume as well arthroscopically as it can open, I'll lean them towards open surgery. If I have a first-time dislocator, maybe non-contact athlete, and they want surgery, I'm going to definitely address that arthroscopically. The jury's still out on contact athletes. In my hands, I feel much more comfortable with the results of open surgery in a contact athlete, so I still go that direction, but that's kind of open for debate. Again, these are just more studies showing, again, there's some better and better results coming out. This one's been talked about a lot recently because of the Journal of Bone and Joint Surgery, showing open repair has a significantly lower risk of recurrence. But again, you really have to pare through the data, and that's what they did in this. Again, if you're going to do open surgery, you want to push it a little bit. Who should you push it in? The patients that have bone loss or younger males, who have a higher redislocation rate. This has been something that's been used. This is interesting, the Instability Severity Index score, and showing the role of arthroscopic versus open. Interestingly, this author talks about arthroscopic open and then a bone reconstruction surgery like a Latarjet. And if the score is less than 3, you can definitely recommend arthroscopic repair relatively safely. If it's over the 3, then you start to think about some open surgeries like Bankart's or capsule repair. And as the numbers get higher, even think of bone restoration procedures. And then Latarjet, so I don't know if everybody knows what the Latarjet is, but a Latarjet is taking the coracoid process and moving it over to the anterior inferior glenoid to restore the bone loss of the glenoid. And we're starting, this is another kind of a randomized prospective study showing that in young patients, you're getting some really good results with this procedure. I think I have a picture coming up. So here's an outcome. This is really catching on because it's become very popular in Europe, and now it's moving over to the United States. The redislocation rates are very low. The outcomes are very good. The problem is you have to be comfortable with the procedure because the complication rate in patients and physicians who don't use it a lot is relatively high. So this is I'm just going to go over the surgical technique very quickly. This is open stabilization. Here's your anterior inferior glenoid. You can see it's a normal pear-shaped glenoid, so you don't have any bone loss. Basically elevate the labrum and the capsule off of the rim, roughen it up, reattach it with anchors, and then maybe if they have increased capsular volume as you're going out, do some form of a capsular shift. And this is my go-to in either redos or contact athletes, or somebody has an element of capsular laxity that goes with it. If we're doing it arthroscopically, this is now you can see the entire glenoid. Here's your Bankart lesion. The labrum's sitting right where it belongs. It hasn't pulled away. It just hasn't healed down. So again, arthroscopically, roughen up the glenoid, put some sutures through the anchors into the glenoid rim, reattach that labrum, and restore that bumper effect. What we're seeing more now, again, is how do we address the capsular laxity? And I think this is why the outcomes are getting better, because in the old days, it was really just reattaching the labrum however you could get it. But now as we improve our surgical techniques, the picture where they've been restored. But in addition to that, the capsular volume is being decreased by doing a capsular plication on the inferior and posterior inferior aspect of the glenoid rim. The labrum isn't attached here, but you're taking capsule and reattaching it so that you decrease the volume. And I think, again, that's why we're seeing better outcomes with arthroscopic techniques. And then glenoid augmentation. So let's just say this is an example of a patient who has glenoid bone loss. They have that inverted pair where they've lost bone on the inferior glenoid either because of a bony Bankart or because of recurrent dislocations. They've just worn away the glenoid. We take the coracoid process and detach it. We still maintain the attachments of the short head of the biceps and the coracobrachialis, screw it onto the anterior inferior glenoid. Number one, you've kind of restored and even exaggerated the pear shape of the glenoid. And number two, when the arm is brought up into abduction and external rotation, the short head of the biceps and the coracobrachialis theoretically act as a sling to prevent the humeral head from escaping out anteriorly and inferiorly. So as far as bony Bankart lesions are concerned, again, with bone loss, you worry about whether you can treat them arthroscopically. I think you have a relatively small bony lesion where you can get sutures through the Bankart lesion, and it's acute. It's not a chronic case. You can probably put that back arthroscopically, but if it's a big piece, you're probably better off doing it open and either screwing it back into place or suturing it back into place. Sorry. And this is just an outcome study. This was out of Italy, comparing doing bony Bankarts early versus late and seeing that the outcomes are better in early treatment versus chronic treatment, and I agree with that. So in that first MRI arthrogram that I showed you where I had a big bony Bankart lesion, I'm going to try to address that surgically because I'll have a good healthy piece of bone that whether I put it back arthroscopically or open, I'll get good bone-to-bone healing, and that's a chance of getting a stable shoulder versus waiting for time for that bone to erode, soften, and maybe completely disappear, and then having a more difficult reconstructive challenge. So just more data to show that. So in summary, I think, this is a big topic. I wanted to hit on some important points. What I think is that non-operative management of anterior instability is relatively low risk, even for in-season athletes. So we don't need to jump on every first-time dislocator and tell them they need surgery. You don't need to take them out of competition, and there's a fair number of athletes who will be managed through their athletic career non-operatively, get into real life, and never need a shoulder operation. Again, I think one of the questions, well, will I get shoulder arthritis? But if you look at the long-term follow-up, probably the biggest risk factor for shoulder arthritis is a shoulder operation that made the shoulder too tight, as opposed to a shoulder operation where the shoulder is a little too loose. Surgical management definitely decreases the risk of recurrence. So if you need a patient who needs to be stable, you should recommend surgery for them. Surgical management in contact athletes, still probably considered a better option, but I think there are many surgeons who are getting so skilled at arthroscopic techniques that question is still open for debate. And I think you need to glenoid bone loss is something that in the last, I would say, 5 to 7 years has come to the forefront and probably is a main reason that the arthroscopic cases with the failures, they weren't recognizing glenoid bone loss. So paying attention to that on radiographs and MRI arthrograms and CAT scans may increase your good to excellent results. But beware of that in patients that are chronic dislocators and the ones that have failed, well done surgery, think it's gone well, but they redislocate. Why? You may not have recognized your bone loss. So that's it. Big topic. Any questions in terms of management? Jeff? No, actually, ladder J's are, you can almost you can treat them with no sling, to tell you the truth. You don't really have to protect those patients at all. And going back to a case I did a long time ago, I had a kid who had been dislocated for, I think, it was through our clinic, which is indigent care, so they don't get to the doctor very quickly, and came into clinic with his shoulder dislocated and had been out for 8 weeks. So by 8 weeks, he had eroded the back of his humeral head, eroded the glenoid, and he was young. He was like 20 years old. So we actually did a ladder J because we knew he had already had the bone loss. He's a typical 20 years old, comes back to clinic 10 days later, no sling, just moving his arm, and his shoulder was stable. So it's probably a more durable operation. Problem is there are the complications that exist with it, like non-union of the coracoid, a fracture of the coracoid, things like that. It's an operation that you need to have in your repertoire and do regularly enough to be good at it, or send your patient to a physician who does it on a regular basis.
What's your explanation for why people dislocate once they get older? Is it just activity level that decreases the recurrence rate as we get older, or is there more to it in your mind?
I don't know. I think they get, number one, they have a little bit of capsular stiffness. Number two, certainly in the older patients, you worry that the things we worry about more in older, when you're talking older, like over 40 or 50 years old, now they have, their dislocations may occur more on the humeral side. Like the pathology may be more capsular rotator cuff issues, and that may have a potential to heal. But I think it's a combination of activity level and just stiffness of their tissues. They're not out there diving into second base head first, usually.
I tell my patients that, the one good thing about getting older is you get a little stiffer.
Right.
Right? We do get a little stiffer as we get older, and in this maybe one scenario, it actually helps us.
It helps us, right. Yeah, even for the ones who's dislocated in their 20s, if they can make it through their 20s without surgery, they're probably going to be okay the rest of their life. So I try to tell them.